Hi, I'm Dr. Timothy Murray from the Miami Ocular Oncology and Retina Service, and it's really my pleasure to speak to A Cure in Sight for I Believe 2020. My topic, I think, is an incredibly important topic for patients that have undergone radiation therapy for malignant melanoma, or in fact, for any other type of cancer. And we're going to talk today about radiation maculopathy and why today it's a treatable condition for you. I do have data from what's called an investigator-sponsored trial, and I do have some disclosures. I have worked with Regeneron Pharmaceuticals, I've worked with Alcon Surgical, and I'm a consultant for the FDA. This is what we're talking about in terms of the tumors that we're treating now. You can see the optic nerve and the blood vessels in the retina, and above this is a malignant melanoma that is next to the optic nerve in the macula. It has orange pigmentation and a focal detachment of the retina. Those are important signs for a melanoma. But we're going to assume that the diagnosis has been correctly made, malignant melanoma, and the eye has been treated with some type of radiation therapy. In our institution and the majority of institutions across the country, that's an I-125 brachytherapy plaque or episcleral plaque. At some institutions, for example, Mass Eye and Ear, they use proton beam radiotherapy where the beam is shot into the eye. It doesn't truly matter for the treatment of radiation retinopathy how the eye was treated. And the major problems with radiation therapy for ocular melanoma are the complications, because in fact, radiation therapy is incredibly effective for treating the tumor within the eye. But patients then went on to lose vision from complications from the radiation, the most common being what we call radiation retinopathy, where the blood vessels in the retina are damaged and they can leak or bleed. It turns out that the closer your tumor is to the optic nerve or the center of the macula called the fovea, the more likely you are to have a radiation complication. And we discussed that as a dose-dependent response. Finally, it is interesting that there's a delayed onset of damage. So in some of the trials that we'll talk about, the radiation damage wasn't recognized early. We believe there's been significant advances in both the detection of radiation retinopathy and in the treatment of radiation retinopathy, and that's what we're going to talk about today. So the treatment has moved toward the use of anti-VEGFs, those vascular endothelial growth factor binding agents that are typically approved for the use of neovascular or wet macular degeneration or diabetic macular edema, and then Triamcinolone acetonide, which you'll also hear about, which is a steroid. In the best clinical trial that was done to date, the Collaborative Ocular Melanoma Study, they used photographs to look at whether or not a patient had radiation retinopathy. And it turns out that photographs really underestimate the incidence, the prevalence, the findings associated with radiation retinopathy. And the development of new technology called optical coherence tomography has really revolutionized that view. So if you see, by 1 year after plaque therapy, by photographic review, only 9% of patients have evidence of radiation maculopathy. But on the OCT, which is like almost a microscopic slice of the eye, 78% had this. So this is incredibly common. And in fact, by 2 years, 98%, and by 5 years, 99%. And again, the risk factors were the same that we talked about. It's important to remember one number. So in the Collaborative Ocular Melanoma Study, by 3 years after plaque radiation, literally the average vision was 2200, which is on the border of legal blindness. So those eyes were treated with radiation, and the tumor was cured, but the patient was blind. What we're talking about today is how do we avoid that? So by many investigators, many of whom have spoken here at I Believe, we've utilized anti-VEGF injections that were developed for wet macular degeneration, and we've shown that you can preserve the vision. And in some cases, we've used intravitreal triamcinolone acetonide to do the same thing. Steroid injection, which is the triamcinolone acetonide, may elevate the pressure, and it also is associated with progression of cataract. So what we're talking about is looking at studies that would define the best treatment for our patients. So the study I'm going to talk to you about is kind of unique, and the reason it's unique is there are very few clinical trials in ocular oncology that have a randomized treatment. That means half the patients get one therapy and half the patients get the other, and then you can truly compare. So in our study, everybody got treated with an I-125 radiation plaque for the primary tumor, and then they were watched every 4 months after the primary radiation therapy. And if they were detected to have an abnormality which was consistent with the radiation retinopathy, then they were treated in one of two ways. Half the patients got an injection that was scheduled every 6 weeks, and half the patients got an injection that was scheduled at what we call a treat and adjust. So they were seen at 6 weeks, and if the leakage got much better, they could extend to 7 weeks. If the leakage got much worse, they would come back in 5. So we would adjust the follow-up. And of course, all the patients are continuously evaluated to make sure there's no evidence of tumor spread or metastasis, and there's no recurrence of tumor in the eye. The way we treated patients is pretty much the standard across the United States. We used the collaborative ocular melanoma study configured plaque with the iodine 125. We treated to a fixed dose of 85 gray. That's how much radiation goes to the tumor. And that appears to kill 99% of all of the tumors that we treat or more. And we had a margin around the tumor to make sure that we didn't skip any of the areas of treatment. And for us at the Miami Ocular Oncology Service, we use intraoperative ultrasound to make sure the plaque and the tumor are perfectly placed. All of our patients have gone through this, and this is what it looks like. On the top screen, you see that is the ultrasound of the melanoma in the patient's eye. On the lower left, you see this gold-based plaque. That's the radiation plaque that is actually sewn on the eye. And on the lower right, you can actually see the radiation plaque centered around the tumor. So you're 100% certain that all of the tumor has been treated. So to get into this study, you had to have radiation and your tumor had to be controlled. We had to have the opportunity to watch you, and you had to have high-grade radiation retinopathy or maculopathy, and we used a grading scheme from 1 to 6. 5 and 6 were the worst grades, and that was what was required to be treated. And this was done under what's called an IRB. That's an Institutional Review Board approved treatment with an informed consent for every patient. We used the drug aflibercept, which is one of the most advanced anti-VEGFs, and its trade name is Eyelea. And we treated patients with that injection no matter which arm you were on. You either got it every 6 weeks or you got it with an adjustment treatment. We treated 40 patients initially, and we reported the 1-year results, and we reported that the results were actually amazing. So patients entered with 20/80 vision on average, and they had a macular thickness of almost 500 microns. And in that first study, the average follow-up was 27 months. What was remarkable is, and you're going to see these pictures here, how much improvement actually occurred. So this is the eye of a 76-year-old who was treated 11 months ago for the malignant melanoma temporal to the macula. You can see the brown pigment, and the patient noted a 6-week loss of vision in the eye. Now, we would rather you come to us immediately when you notice a decline in vision, but this patient came at 6 weeks. And this is what an OCT looks like. You can see that it's actually very thickened, and that thickening is due to the diffuse leakage, what we call edema, from the radiation retinopathy or maculopathy. This patient's vision was 2400, legally blind in this eye. This patient was now treated for 5 series of injections every 6 weeks for over a year, and this looks almost normal. And the vision has gone from 2400 legally blind to 2030. So this was the kind of results that we were seeing that we thought were incredible. This is a second gentleman, 79 years of age, and after I-125 brachytherapy at 14 months, Again, 5 weeks of a decline in vision, very large tumor. This is lipid, the yellow in the macular region from the ectate. And then, of course, here is the OCT, or the optical coherence tomogram. The leakage is all the splitting of the retina with the clefting and dark spaces. That's fluid, and that also can retain blood. So this patient's vision isn't as bad as the first patient's. It's only 20/80. So that was the average entry level of visual acuity. But this patient was treated every 6 weeks for 74 weeks, and vision recovered to 20/25, 1 line less than 20/20. Spectacular improvement in vision. And this patient is a 54-year-old woman who was treated 8 months earlier and has had only a 1-week decline in her vision. But you notice that the optic nerve is swollen and there's retinopathy, but the tumor is controlled. Here, the vision again was 2400, legally blind. And this patient entered the study, was treated with a treat and adjust, and she was able to start at 6 weeks of treatment and move to treatment every 7 weeks. Not a lot longer, but 1 less injection in a year, and 66 weeks later, her vision is 20/30. So what we do with trials like this is we take all of the patients and we look at fixed time points, and we try to look at the statistics of the treatment to make sure it worked. So bottom line is, in the first year, we had 40 patients complete the study, and they did beautifully. But the question has been, will it continue to be beautiful? And so this second arm of the study took 30 of the 40 patients, because the group with the investigator support would only support 30 of these patients to be treated, and they were treated for an additional year. And what you see is how well they did. So the retina went from that 500 microns of thickness down to 390, and ultimately by 2 years down to 263. Each of those stages of review were statistically significant. The vision started at 20/80 on average, improved to 20/63 at 1 year, and 20/62 at 2 years. Fully 3/4 of the patients had vision that was 20/40 or better and would have passed a legal driving test or could read with this eye. Remember, 3 years after treatment, which is when this 2-year group is in the COMS, the average vision was 2200, which was legally blind. And this was significantly associated with improvement on our statistical analysis. Now, how many injections did patients get? Because my patients are always like, how do I have to do this forever? And in the fixed treatment group, patients got 9 injections. Adjusted, they got 8.5 injections. In the second year, it dropped down to 8. So what does that tell you? It tells you that patients continue to need to be injected through the first 2 years of treatment. And likely, most patients will continue to be injected through the course of their life. But that injection preserves the eye, the function of the eye, and the patient's sight. So in any study, you always have to make sure that you didn't compromise the patient's survival. So none of our patients died, which was expected. None of our patients developed metastatic disease, which was expected. All of the tumors were controlled. There was 1 patient that had inflammation after the injection, and we know that can occur with the aflibercept. And that patient was a physician, a doctor who actually recovered 20/20 vision. And no cases showed an infection that could be associated with these injections into the eye. So what did we take home from this? So this is the longest, largest, extended randomized clinical study of the treatment of radiation retinopathy with aflibercept. And what does it show? It shows that patients recover and improve their vision, and that recovery and improvement of vision is sustained. It's a small study. It's only 40 patients, and most of the studies for these kind of issues are small studies. But it does tell us that in our hands with this treatment, patients can continue to do really well. So what's the real take-home message? Radiation retinopathy no longer needs to be a blinding condition. Early screening and early treatment are key. ongoing treatment is critical, and the interval to treatments have to be relatively short. If you don't get injected enough, that is the major reason that patients lose vision. And the biggest advance besides the anti-VEGF therapy that we used has been the optical coherence tomography imaging that lets us microscopically evaluate the retina. So the combination of new technology to look at the eye and new treatments to preserve the vision have revolutionized our ability to take care of our patients. Now, like anything else, you want support from other investigators. This is Dr. Ivana Kim at Mass Eye and Ear, and she looked at 40 patients and treated them with ranibizumab every 2 months, and they also did significantly better than patients that were not treated. This is Paul Finger's initial study, 14 patients, and he treated them after the plaque and every 4 weeks with bevacizumab, one of the third anti-VEGF agents. And he suggested that that not only delayed the development of radiation retinopathy, but it improved the outcome for the patients. And then, of course, Dr. Carroll and Jerry Shields have looked at the largest, most amazing amount of patients, which was 1,131 patients. They gave the treatment immediately after the plaque and continued every 4 months. And their patients' vision at 4 years averaged 20/70, a little less than our patients, but still outstanding. Scheffler and all are looking at publications that will look at a randomized study, and that is not yet available. So for all of our patients, it's important for us to realize that treatment requires control of the primary tumor in the eye, a radiation source treatment that damages the vessels, screening of the patients with OCT, and treatment with an intravitreal or eye injection of anti-VEGF. But you can know that you have the chance to keep driving and reading vision in an eye that in the past would have been removed and placed in a jar in the lab, or would have been treated with radiation and had been your eye, but a blind eye. So I think that there is much excitement within our field about the opportunity to not only effectively treat our patients with melanoma, but to preserve their vision. And I think that's exactly what A Cure in Sight is all about. And that's why I was happy to participate in I Believe 2020. Thank you. How'd we do? Mute, 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 mute. Hi, Lauren.
Hi, Dr. Murray. Thank you so much.
Is that okay?
Awesome. Hold on. Hi. Thank you.
So Lauren's off mute, but you're still on mute.
Okay. I think that Dr. Murray, I have a question. Usually your study took place right after a patient was diagnosed with ocular melanoma, right after plaque. Is that, it's pretty, this took place within 12 months of plaque?
So what this tells you is that, let's see if I can do this. I'm trying to close the share, but I can't. There we go. So the way this worked for us is that we had already shown Lauren that if you do an injection at the end of the plaque with an anti-VEGF, that enhances the anatomy of the eye. So since for over a decade now, when your plaque gets onto the eye and when it comes off of the eye, you get an injection in the eye in the operating room when the plaque's removed. For me, that's not a standard around the country. But that anti-VEGF was part of the clue for me to believe that we could use anti-VEGF to stabilize blood vessels going forward. So what happens in my practice is you go to the operating room for your plaque's put on the eye, it stays on the eye typically for 3 days. We take the plaque off and I inject an anti-VEGF in the operating room. You go home and you come back and see me in 2 weeks, and then in a month, and then in 2 months, and then in 3 months. And on those visits, every one of those visits, you get pictures of your eye, photographs of the fundus and the tumor, and you get OCT of the macula. And if on any of those visits we see leakage in the eye, you immediately get treated. And once we see the first evidence of leakage, we don't bring you back again in 4 to 6 months. We bring you back in 6 weeks. And if in 6 weeks you still have leakage, we inject you again. If the leakage is less, we go a little longer. If the leakage may have been more, we go a little bit shorter. So that's where you get an injection, and then based on your exam, you get adjusted in terms of when you come back. And that seems to be the most common strategy that doctors are using for treating macular degeneration and diabetic disease. And because I get to treat both of those within our practice, within the ocular oncology practice, it allows me to kind of take from one field of study and apply to another. So for us, that's the key. The key is to detect it early and to treat aggressively, and for the patients to understand that it's a repetitive treatment. This is not a one and done. So when some doctors started to use anti-VEGF, for example, they would give one injection and 4 months later, they would give you another injection. And it turns out that once radiation retinopathy develops, every 4-month injections are ineffective. Turns out they're also ineffective for wet macular degeneration. Some patients need a lot of injections and some patients may need less. So I think the key to this is you have to really personalize the medicine. So you don't come into my office and get a schedule. You come into my office and you get evaluated, and based on that specific evaluation with you that day, you get treated, and then you get told when we'll look again. So you know that in your case, you've been treated, and it has been remarkable that these treatments for 2 different conditions for you have literally saved a portion of sight for you when no one else would have been able to see. That's the excitement for me. It's amazing.
I have a quick question for you.
Sure.
If my doctor's giving me Avastin and it's not, and it just seems to just be holding its own, when is it time to have that discussion to move to a different, like Eyelea or another medication? When do you know it's time to stop and move forward?
So for us, we did this trial with Eyelea because it was the most advanced agent, but virtually all our patients get treated with Avastin, which is bevacizumab. And the reason for that is that because there's no clinical approval for anti-VEGF treatment in radiation retinopathy, if we use one of the very expensive medications like Eyelea or like Lucentis, most of the insurance carriers will not pay for that. And many of my patients, if not all of my patients, cannot really afford an extra $2,000 charge to pay for the drug itself. So what we'll do in our patients is we'll use the anti-VEGF often. And then we couple it with a steroid, the intravitreal triamcinolone acetonide, or what's called Triamcinolone. That has been a very effective strategy. We've really almost had no patients that did not respond to that. So when patients don't respond, the most sort of pivotal moment is how often are you injecting the patient? So I shorten my injections significantly. Some of the patients for this and for other diseases get injected every 3 weeks. Some of our patients get anti-VEGF alternating with steroid. So it really requires that your physician, who's your oncologist and your ophthalmologist, be comfortable in sort of treating all of the different variations that this can take. And I think if you're a patient, you should ask. If you're uncertain as to how you're being treated or why you're being treated or what the drug choice is, that's what you're sitting in my office to discuss.
Okay. What do you think about?
That's a great question. And you
would about Ozurdex pellets, the Ozurdex pellet?
So I have not really been happy with the Ozurdex pellets personally. It hasn't really shown a big benefit. The Iluvien, which is a sustained release drug that lasts much longer than Ozurdex, for us, that's had more of an interest, but there have not been really any good clinical studies with that drug yet. Mm-hmm. The advantage to that is it may release for a year or two. So some of us, myself included, think that Steroid targets one arm of the leakage pattern, and anti-VEGF targets the second arm. The biggest problem with steroids, of course, is the development of glaucoma. And in glaucoma, which is where the pressure is elevated, becomes significant, and it is more significant in our hands in patients that have been treated with Ozurdex than it is in patients that have been treated with intravitreal triescence. And that's because the triescence you can control better because it doesn't last as long. So you can keep yourself out of trouble. Okay. I'm less picky about what doctor chooses which drug than that they're looking at their patient often and that they're making choices that are showing improvement for the patient. So Lauren knows when you come into my office, you look at the OCT on the top, which shows what did you look like on your last visit. And right under that is the OCT today. And Lauren will tell you that she's pretty slick at looking at the OCT and saying, I'm better, or damn it, I'm worse, okay? And I think that it's an incredibly empowering component of the visit where you can actually see what I'm seeing and you can understand some of the nuance to what we're deciding. So I think being able to look at your imaging and having imaging obtained every visit is critical. Okay. And I think your doctor has to have access to all of the different drugs and explain to you why they chose which drug. And also you had mentioned earlier, some patients said, I get my sight back. And what you saw is the 3 cases that I presented, all 3 of them got their sight back. Now, there's a small percentage of patients that may not get their sight back, but if you treat early, we've almost seen that being almost 0. So that's amazing. Now, if you start off with 20/20 vision, which some of our patients, in the study that I did, you had to have lost a little vision. So you couldn't be 20/20, you had to be 20/25. But if you're 20/25, it's hard to really know you're better because the difference between 20/20 and 20/25 is sometimes blinking, okay? Right. So I try to make patients understand that when their vision is very good when they start, it's not about making their vision better. It's about preventing them becoming legally blind. And that's exactly what happened before these drugs were available. So we know what happens if we plaque you and you get radiation retinopathy, optic neuropathy, and you're not treated. You are legally blind in that eye. What's even worse is that probably in the CMS study, 1 in 6 of the eyes that were plaqued had to be removed because of complications from the radiation. If you're getting followed and injected like we're talking about, in the last 10 years, we have not had to remove a single eye. So that's over 100 eyes that didn't have to be removed in my practice alone. So it's not just about the vision to me, it's about the vision and the function and the quality. Now the downside is it sucks to come to the doctor's office and get an injection. Nobody likes that. Yeah. But I try to help my patients understand what you're weighing, the risk to the benefit. Life is always about risk and benefit for most of the stuff we do in medicine. So now I respect my patients. I've had patients that say, look, I don't want to be injected anymore. And I respect that. I push really hard. Lauren will tell you that I'm not easy. If you want to do the wrong thing, I'm sitting there telling you no, okay? And I fight with you. But if you fight back and I feel like you understand the choice you're making, I'll let you make a bad choice. Mm-hmm. I wish you wouldn't. So, I've seen so much of this for so long that the question to me is helping patients make really good choices. And then the other thing was you had patients, do you need to get injected forever? Not everybody needs to be injected forever. And over time, you seem to need to be injected less, okay? But you still look like you need to be injected. And at a minimum, you need to be screened with the OCT to see whether you need to be injected. And then one of the other exciting parts of all of this is we're talking about a condition that is really related to radiation therapy. Lauren knows, and you do, that there's some big advances going forward, trying to look at treating tumors smaller and earlier, avoiding radiation. And we have one of our papers just got accepted showing that we can avoid radiation in small tumors in virtually every one of our small tumor patients now. That wasn't even considered possible. So there are big things happening within this field, and it's exciting.
When do you think that some of these medicines might be approved for the radiation damage. Right now they're approved for diabetic or wet AMD, but when do you think that they might be approved, that we could get our costs down and covered by insurance?
So that's a great question too. So the reason that I was able to do this study is that the company, Regeneron, supported the cost of the clinical trial. And so they gave us the drug, and they helped defray some of the patient costs. The idea is to do that. It gives you a foundation that allows the company to consider going to the FDA, and it has to be the company that goes to the FDA. And they say, we'd like to extend the indication. Here's Dr. Murray's clinical trial. Here's Dr. Scheffler's clinical trial. You have 2 clinical trials that show benefit. And then the FDA has the opportunity to review that, and then they can extend the indication. A lot of companies don't want to do that because this is an orphan disease. What's the problem with this? In my office, you think everybody has melanoma or some type of eye cancer, but really in the real world, it's a drop in the bucket. Breast cancer, colon cancer, lung cancer, eye cancer, melanoma. So the companies don't really have a financial benefit to doing this. They're never going to make any money doing this. Mm-hmm. But we've been thrilled that the companies don't always look at this financially, that they're willing to look and say, this is an unmet need. And so Regeneron has considered that, and the Lucentis drug has been evaluated for that also. So I think there's some interest, but it's been slow. For example, I was at Bascom Palmer for 20 years, and at Bascom Palmer for 20 years, I couldn't get a single clinical study about how to treat radiation retinopathy, maculopathy. But as soon as I left, we were able to do that because we didn't have the same university-related constraints. So to take this home, we're hoping that the companies can use the data that we've provided by these clinical studies, these investigator-sponsored trials, to ask the FDA for an extension. Whether they are going to do that or not, we don't really know. One of the things that I think is helpful is you have a large group of very vocal advocates for care. That's a pretty strong group. You guys can easily write to the companies that are involved with this and say, can you help us? And it's really impactful in my experience when patients reach out and ask for a big company that they think's big. They don't really appreciate that those guys have hearts and souls just like we do, and they want to do the right thing. So we're hoping we can give them the data that lets them do that. But for right now, the only one I'm able to use outside of a clinical study is bevacizumab. And the only good news about that is bevacizumab worked really well. Okay, Eyelea might work a little better, and it may allow you 1 more or 2 more weeks between injections, but they both appear to be effective.
Okay, so that was going to be my question about what can patient advocacy do to help get this started. And I'd be more than happy. I'm sure Lauren and I could get patients to do that. I think that would be really impactful if we wrote to some of these pharmaceutical companies to get more involved.
Right. Or even, one of the ways that they could do this too, which is an option for us, is, they may just say, look, it's not worth our while getting approval. There's so few patients that have this condition. Maybe we'll make this compassionate use where we'll give you the drug. So the cost, the problem is the drug is very expensive, and somebody has to pay for it. And if it's not going to be your insurance, then it has to be a patient, or it has to get subsidized maybe by a foundation. But that's really hard. And since this is an ongoing therapy, it's not like one and done. If I only had to inject you 1 time, my patients would be like, okay, I can afford $2,000 extra 1 time. Really most people can't, but maybe I could do that. I've had people that are said, I'll mortgage my house if you can inject my daughter. And I'm like, look, I don't think you need to do that. I can use other agents, but we always like to have the broadest sort of armamentarium of treatments available to us. So we'd always like to be able to do that. And in the eye cancer field, it's been incredibly restricted.
Well, we hope that changes with clinical trials and maybe some patient advocacy. Maybe we can change that and save some vision, because that's what all of us patients want, is we want to keep our vision as much as we can, because it's, you know, living with only one eye is not that great.
Right. Well, you know, the world has changed a lot, because when I started, the most common treatment of bascom palmer was having your eye removed. You know, that changed really quickly, thank goodness. So really, we rarely take an eye out anymore. So we went from, you have to be kept alive, that's our #1 priority. And we thought in the past that that required your eye to come out, but we know that's not true. So you can keep your eye, but it's like, if you're going to keep your eye, what does that matter if it doesn't see?
Right.
So you're absolutely right. So everything feeds forward. Now, the farther that we've gotten, you know, we're really setting our standards and our expectations a lot higher. You know, I can remember that even when I started plaquing patients routinely, when I came to bascom palmer, the radiation oncologist that I worked with told every one of my patients they'd be blind by 5 years.
Wow.
So now I look at my patients that are like 25 years later, and I'm like, go call Dr. Marco up and tell him you can read the paper, okay? So I think that one of the things too is that, you know, we have to have hope, and we have to continue to push forward. You know, nobody accepts that you have to die from this disease. Nobody accepts you have to lose your eye, and nobody accepts you have to go blind. And that's where advocacy makes a big difference. That's why I think this was important.
Thank you. Well, thank you so much for giving us your time. I have one quick question that doesn't really have to do with this, but this is a question that always comes up. Have you seen an increase in cases? It was saying about 2,500 people a year, 5 in a million. Have you seen an increase, or is it pretty much holding steady?
So I think one of the things that you can think of as an increase is that patients with smaller tumors are getting treated earlier.
Oh, okay.
So what used to be called, maybe this is an atypical nevus and we're going to watch it, many of those patients clearly to us clinically have small malignant melanoma. You've heard some people say that treating the eye doesn't make any difference. And that cuts me to my core, because I don't believe that. I think the data very clearly shows that the smaller your tumor is when you're treated, and the more effective the first treatment is, clearly the better the survival and the better the outcome visually for the patient. So I think that we're treating earlier, we're treating smaller, our patients are doing better. I think for tumors in the medium to large category, I don't feel like I'm seeing more of those patients. You know, there's been some interesting clustering. So the cluster in Georgia that the Shields are looking at, I think that's fascinating. You know, we don't understand the genetics of this tumor as well as we would like, but we sure understand the genetics better than we ever had before. And one of the things to this too now is that we can do biopsy of the tumor to allow us to look at a genetic prognosticator for the patient. That's huge. And one of the things I love about that is that when I use, you know, Castle Biosciences test, and it gives me a class 1A, 1B, or 2. And a class 2 sucks, right? So if you look at the statistical data, class 2 it's not pretty. But what's interesting to me is every single one of my class 2 patients that have had a small tumor, they're all alive.
Oh.
So class 2 mortality it's more than just the genetics. It does have a clear size component to this. So I think what that tells me is, boy, if I can treat you small with a class 2 and you're alive to tell the tale a decade later, and if you wait till your tumor is a medium or a large class 2 and the mortality rate is 78% at 5 years, it tells me treat earlier. I believe that. I think that the Shields believe that. I think multiple investigators in the United States who have been doing this for a long time really do believe that. The problem was everybody argues from the past, and there's a big push outside of the majority of the ocular oncology community that says, you can't tell me that's melanoma. I think that's an atypical nevus. And you can go back and forth in that forever. And in fact, the first small tumor clinical trial that I wrote for the National Cancer Institute, the major complaint was that we couldn't tell what was a melanoma and what was a nevus. Having said that, every single person that was an investigator said, I can tell. So a good clinician can make that distinction. And so we want our patients to see experts in the field. So even retina specialty is a really expert specialty. Oncology is the sub specialty within that retina group. So, you know, the biggest thing that frustrates me is when patients don't get to us in time, and that happens multiple times a year for me. And when patients have some type of inappropriate first treatment, because we have really good data that says the first treatment has to be really, really good. You don't want to give somebody the first treatment and say, let's see if it works. That doesn't work for cancer, okay? What you want to do is cure it the first time. Don't wait and do this, and then maybe we'll do this and do that. I'm really opposed to that. And I think there's data out there that suggests that there's good reason to be opposed. Having said that, there's more discussion and more research on ocular melanoma, I think, than has happened in 2 decades before.
Well,
so kind of cool.
Yeah. Well, thank you so much for being with us. Thank you so much for—
Can I ask you a quick question, Dr. Murray? One quick question. Did you say years ago you studied under Dr. Elsner in New York back in the day?
Ellsworth was the person that was an expert in New York on retinoblastoma.
Okay.
And Dr. Ellsworth's practice, it was recent Ellsworth, that was taken over by Dr. Abramson. He's amazing, okay?
Well, the reason I ask is because you met my aunt who's 98, and she was, remember? Aunt Marilyn, who was diagnosed by him with ocular melanoma, and she's still here. She's 98. She's still kicking.
Yeah, so you're still kicking too, Lauren.
I know. We're coming on 20.
I know. I love it. But those are the success stories that we see every day in the clinic.
Yeah.
And the problem is if you're not in the heart of this, if you're not treating patients every day, you're not seeing where the field's going, and you're not seeing the advances. So what you would have heard 25 years ago is not what I just told you today, okay? And that's because we have patients that push us. We have doctors that are passionate. We're in this to keep our patients alive with their eyes and vision. And I think that there's not one of the ocular oncologists that I know that is not driven really to do that day in and day out.
Well,
so thank you guys.
We hope to have you back next year. And if you ever want to come on and give it for one of our podcasts, if you have a subject you'd like to talk about, we do have a podcast. We'd love to have you back. So, and you know what, I'll tell you, you had some really good back and forth questions and answers that I got to listen to. You've got some really amazing speakers, so I'm really happy for that. I thought I heard some, the question and answer sessions that I got to listen to were superb. So I'm happy to participate with you guys in any way that I can. I think these are really important opportunities for my patients, but also for all of our patients. Okay, well, we'll see you again soon. Thank you so much.
Bye.
Bye.
Thank you.